Good afternoon. I would like to welcome you all to today's webinar. I am Lori Gregg, Senior Program Officer in the Health and Medicine Division of the National Academies of Sciences, Engineering, and Medicine. I direct the Roundtable on Quality Care for People with Serious Illness, a convening activity here at the Academies, and one of the co-hosts of this webinar. The National Academies serve as advisors to the nation on particularly complex health challenges. Given the urgency of the unprecedented public health crisis created by the COVID-19 pandemic, we have developed a series of targeted webinars to help facilitate broad dissemination of useful information about innovative strategies to address the myriad critical challenges related to the pandemic. The first webinar in this series was held on April 22nd and highlighted the novel approach implemented in the state of Maryland using rapid response strike teams to help keep nursing home residents and staff safe. Earlier this week, we hosted a follow-on webinar which highlighted effective testing and cohorting strategies to limit transmission of this deadly virus among nursing home residents and staff. For today's webinar, we have convened a panel of experts who will share their perspectives on and lessons learned through their development of hospital-based palliative care responses to the pandemic. This webinar was organized by a collaborative team of Academy staff that includes the Board on Population Health and Public Health Practice and two convening activities under the Board on Healthcare Services, the Serious Illness Roundtable and the Forum on Aging, Disability, and Independence. We hope you will be able to participate in upcoming webinars hosted by this team, including one highlighting best practices for patient-clinician communication for people with disabilities in the era of COVID-19, which is scheduled for June 19th. This webinar is being recorded and the archived video will be available at the link provided at the end of the webinar. Due to time and capacity constraints, we will not be using the chat function on Zoom today. I now have the pleasure of introducing Dr. Amy Berman as the moderator of this webinar. Amy is a Senior Program Officer with the John A. Hartford Foundation, where she leads the Foundation's development and dissemination of innovative, cost-effective models of care that improve health outcomes for older adults. Among these efforts, Amy is responsible for the Foundation's work on age-friendly health systems, as well as efforts to advance palliative care. The John A. Hartford Foundation generously supports two of the National Academy's convening activities I mentioned earlier. Amy is also a nurse and a person who openly shares her experience as a person living with serious illness who receives palliative care. We are extremely fortunate to have her as the moderator of this webinar. I turn now to Amy, who will provide an overview of the webinar and introduce our speakers. Amy?
Thank you, Lori. Good afternoon and good morning to our friends out west. Today, we will hear from leading experts about innovative hospital-based palliative care responses to COVID. The John A. Hartford Foundation, where I work, has been focused on improving the care of older adults, and we've been a longtime supporter of palliative care, a key component of age-friendly health systems. And as Lori mentioned, I also have lived for nearly 10 years with stage 4 cancer. And I must tell you, I live well because of palliative care. So thank you to our panelists in advance. I want to thank the Academy for its ongoing attention to the needs of the seriously ill and for its timely attention to sharing better practices like these related to COVID. I also would be remiss if I didn't point out the disproportionate impact of COVID on communities of color, that racism continues to be a public health crisis. And in the face of the needless death of George Floyd and others, I want to share the words of Archbishop Desmond Tutu. He was a great leader who helped to peacefully end apartheid. And he said, "My humanity is bound up in yours, for we can only be human together." And with that, I'd like to turn to our exceptional panelists. Next slide. We will hear from Sean Morrison, Chair, Geriatrics and Palliative Medicine at the Mount Sinai Health System the Ellen and Howard C. Katz Professor at the Icahn School of Medicine at Mount Sinai. We will also hear from Emily Chai, MD, Vice Chair for Patient Services, Geriatrics and Palliative Medicine, also at Mount Sinai Health System, and a professor at Icahn School of Medicine at Mount Sinai. Then at Brigham and Women's, we will hear from Jane DeLima Thomas, MD, Clinical Director of Adult Palliative Care at Dana-Farber Cancer Institute and the Brigham and Women's Hospital, and Assistant Professor of Medicine at Harvard Medical School. She's also the Associate Director of the Harvard Interprofessional Palliative Care Fellowship Program. And Elizabeth Rickerson, MD, Clinical Director and Intensive Palliative Care Unit within Dana-Farber's Cancer Institute, also Brigham and Women's Hospital, and an instructor of anesthesia at the Harvard Medical School. And finally, last but not least, we'll hear from Barbara Revel, a nurse director of the Palliative Care Department of Psychosocial Oncology and Palliative Care, the Fellowship Director of the Palliative Care Nurse Practitioner Fellowship, and at the Harvard Medical School Center for Palliative Care. Phenomenal panel, and I welcome you all.
Thank you, Amy, so much for moderating this. It really is a pleasure to work with Amy and others. And our role, Emily and my role to begin with, is to talk a little bit about what happened in New York City during the COVID-19 pandemic. And Emily is going to talk a lot about new systems that we put in place to respond to the pandemic. Can I have the next slide, please? So just a very quick background. The Sinai Health System is a 6-hospital system in New York City and in Nassau County, Long Island. It consists of one 1,100-bed academic medical center, 4 500-bed community hospitals, 2 200-bed community hospitals, and that totals to about 3,000 beds and just under 300 ICU beds, or 283 ICU beds. And I want you to remember that last 283 number. And this is what our hospitals looked like on February 1st. April 8th was the surge of the pandemic, and this is what our hospital system looked like on April 8th. Of the 3,000 beds that we had, 2,000 were occupied by patients with COVID. And remember that 293 bed ICU that we had, or the 293 ICU beds across the system. On April 8th, we had 450 COVID patients, not including everybody else, in ICUs. Bottom right-hand corner, you can see our new hospital, Mount Sinai Central Park. And on the bottom left-hand corner, that's the emergency department at South Nassau Mount Sinai Hospital during the midst of the pandemic. Next slide, please. So the challenges that we were facing were several. We had an overwhelming number of critically ill patients with high symptom burdens. Our emergency medicine physician were facing unprecedented numbers of patients requiring respiratory management and indeed intubation. Our critical care units were operating at 1.6 times maximal capacity. And our COVID-19 medical services, which were staffed by deployed physicians, which were both physicians from outside of New York and the Mount Sinai Health System, and rehab medicine physicians, ophthalmologists, dermatologists, who were facing multiple difficult treatment decisions on a daily basis. Next slide, please. And at the beginning, and as we moved through the pandemic, there were 4 areas that our health system identified as critically needing palliative care. And we're going to talk about 3 of those 4 today. One was our emergency department, one was our critical care units, and the other was our hospital medicine services that were caring for 3,000 patients with COVID-19. Next slide, please. So I'm going to turn things over to Emily, who's going to walk you through the innovations that she and her team developed to meet the needs at those three key areas. Em?
So let me start with the palliative care helpline, which is known to the health system as the Patch 24 because it's a 24-hour line that is staffed. It was initially initiated as an attempt to be able to reach all of the Mount Sinai Health System COVID-19 patients. And the idea behind that was that we were going to provide teleconsultation to frontline providers. We started the planning around late March and started getting out calls about 3 days after we started the planning. The initial plan was to staff this with 2 certified palliative care physicians, each with a 12-hour shift. Next slide, please. What I'm going to do is I'm going to actually use this telephonic 24-hour line to share the principles and lessons that we've learned. Many of these lessons and principles actually apply to our 2 other programs, which I will share with you later. Next slide. So the first thing we've learned was that we needed to adapt and innovate quickly. And everything seems to be changing every 24 hours, sometimes even less. For example, we started out with 2 physicians. In less than a day, we realized we needed multiple backups. And over time, developed a backup of over 5 physicians who actually can assist when multiple calls come in at the same time. We initially had these certified palliative care trained physicians as the operators. They were going to take the call, answer directly, and make the, provide assistance and or triage and direct calls to other MDs. We soon realized that was not a good use of our very scarce resource, our attendings, and recruited a bunch of medical students to train as operators and completely ditched the idea of triaging. Next slide. The other thing we learned very quickly was that the frontline physicians did not have time to receive any coaching of any sort, and even less time to conduct any goals of care discussions. Our redeployed clinicians, often from non-medical specialties, really did not even have the inpatient experience and even less the ability to conduct complicated goals of care discussions. So we quickly moved from a teleconsultative service to a telemedicine service where we provide direct patient care. And since we have a growing panel of clinicians taking these calls, we quickly developed and standardized a note documentation template, as well as language that we would use when we're answering these calls, and a way for us to actually communicate from with each other. Next slide. We had initially worked into the workflow of Patch a shift change huddle. And the aim for the huddle was really to determine what the volume was going to look like, and also to determine if there are workflow variations and changes that we need to make. We realized through these huddles that we needed a full-time palliative care physician at one of our smallest community hospitals, and thus deployed one there, mainly because they did not have an inpatient palliative care provider or a team. And we soon realized through the huddles that our weekends were operating just like our weekdays, and we needed to staff up our weekend coverage. Next slide. What was interesting was as we were picking up volume on day 3, after calls started to come in, we received no calls from one of the largest emergency rooms in the hospital. And we knew citywide that numbers were increasing. I made a call to the medical director of the emergency room and soon realized what the problem was, that our frontline providers in the emergency room cannot even lift up the phone to make a call for help. With that, we actually embedded another physician into the emergency room, namely from 11 a.m. to 7 p.m. They provide direct patient care, and they also could actually request the help of Patch 24 if needed, by making referrals directly to the telephonic line if multiple cases come in at the same time. Next slide. As we hit peak and surge, we realized the number of referred patients started overwhelming the staff. Even that 5 backup physicians was not quite enough. We were fortunate enough to have palliative care clinicians from across the country joining us virtually by phone, and they were credentialed through the New York State of Emergency Act. We trained them with 2 hours of training, mainly focused on workflow, culture, how to get the translator, etc. And then we added a physician who would help them with the nuances and the culture of each hospital. Next slide. Not only did Patch 24 support families and patients, they actually supported clinicians as well. Very often, while a physician is calling in a consult or for telemedicine, the first 3 to 5 minutes was spent really talking about how hard their day had been, how hard it had been for the patients that they're actually seeing. And the patch providers actually provided empathic listening as well as resources for the Mount Sinai Health System staff. What initially started out as huddles for workflow ended up being used as support for each other. So our 9 a.m. and 9 p.m. huddles became supports that we use and rely on to support each other. Next slide. So Patch was actually great for crisis response. It really did not, the way it was structured and staff did not allow for continuity. We were initially allowing for follow-ups because the volume was really low, but that did not last for more than a couple of days. And we realized very quickly that follow-up needed to be clear to the people calling in that follow-up is not going to be possible. So if we felt that follow-up is needed, we try to create a handoff to hand it off to inpatient teams. But keeping in mind that our inpatient teams are actually incredibly busy and overwhelmed as well. So very often that resulted in a trade-off, meaning we sign off a patient to our inpatient team and our inpatient team will give us one of the new consults, which could be done virtually. Next slide. So let me move from there and talk a little bit about what we did in critical care. Next slide. So we actually have what we call the cassette program in critical care. It stands for COVID Appropriate Care Evaluation Team. It was actually staffed by experienced intensivists and palliative care team together. And jointly, this was created to meet the needs of the sickest patients within the initial 5 COVID ICUs at Mount Sinai Hospital. That 5 ICUs ended up being 8 at the peak of the COVID surge. The goal was actually to identify patients who are at high risk for mortality or patients who had unmet communication needs. And we were going to generate this through an electronic medical record, send it to the lead intensivist to edit, and then the roster was going to be sent to this team, and we would divide it up based on the needs of each patient, whether an intensivist or a palliative care team member would call them back to assist. Next slide. This is how it initially looked like. We started out with age, SOFA scores, PO2 FiO2 ratios, and whether they were on 2 or more pressors. Very quickly evolved and changed in less than a week or 2 to include length of stay and simply whether or not the clinician feels the patient's condition is stable, worse, or improving. And next slide. Ultimately deteriorated or ended up being that our PAL care physician or clinician go to the ICU with a list of the current ICU patients and simply ask them which of these patients on this list needs a goals of care discussion or needs palliative care. Over the course of COVID, we saw roughly about 20 to 25% of all ventilated ICU patients in the 8 ICUs at Mount Sinai Hospital. Next slide. The last program that we started, having done work in the emergency room, knowing that the sickest patients who come in through the emergency room are actually covered. The sickest patients in the ICUs who look like they're not improving are covered and will have goals of care conversation. It basically left us with everybody else. Most of them are on hospitalist service in the regular hospital wards. And we felt that the only way we're going to be able to catch this group, knowing that our team is already overwhelmed, is really by expanding primary palliative care. So we conducted virtual trainings for over 300 social workers, 45 deployed residents, and 2 attending psychiatrists with focus on value preference assessment, treatment choices, and most importantly, on the identification of surrogate decision-making in the setting of COVID. And I have to say that being able to identify decision makers became a critical point, especially if they end up not doing well in the ICU. Sean?
Yeah, so let me just summarize a couple of key points. First of all, I think it's important to recognize that the New York situation was relatively unique. And I hope that other cities and other parts of the country never have to go through what we went through in New York or what happened in New York. I also want to point out that the Mount Sinai Health System Palliative Care Program is relatively unique. It's quite large, it has a very large scope of services, and it has a fellowship program that includes 15 postgraduate fellows. Nevertheless, I think there were really 3 key lessons that we learned from this. The first is that innovation and flexibility are really critical. Everything that we planned, we essentially had to change, innovate, and redesign almost on a daily basis. That being said, Emily and her team, when they started, used the principles of design theory. They designed for outliers, they pilot tested, they redesigned and innovated, they repiloted, and they kept doing that until they got it right. And then when things changed, they went back and redesigned it again. And then finally, the other thing that the teams did, and I think was extraordinarily both innovative and forward-thinking, is that they were on the lookout constantly for warning signs, which allowed them to adapt and innovate very, very quickly so that the needs of patients and families were met. And I think now I turn it over to my colleagues in the North.
Thanks so much. So I'm going to talk a little bit about our experience at Brigham and Women's Hospital. We're really glad to be here to describe what we've been experiencing over the last few months, and we hope it's helpful for everyone listening. Next slide. So for context, Brigham and Women's Hospital is an 800-bed hospital, including 98 ICU beds. Our inpatient palliative care service has 2 main branches. A consult service that sees roughly 2,000 new consults a year, and an intensive palliative care unit, or IPCU, that admits 450 patients a year. To staff those services, we have approximately 20 physicians who are part-time clinical, 4 NPs, 4 PAs, 5 social workers, and chaplaincy and pharmacy support. Next slide. The surge at the Brigham was later and lower than at Mount Sinai. We think the timing was due to fairly effective social distancing, and that was happening in part because of what we were seeing in cities like Seattle and New York. And at our hospital, the demographics show a lower percentage of Black and Latinx patients compared with other hospitals. And we think that explains the slightly lower numbers of COVID patients who came to us. Next slide. So having said that, we didn't know exactly what was coming to us, and we still ended up seeing unprecedented numbers of seriously ill patients. So we planned furiously, and our surge response ended up having 4 parts. First, we completely restructured our consult service. Second, we refocused our IPCU, our intensive palliative care unit. Third, we created a collection of educational materials that we called our palliative care toolkit. And fourth, having seen what was happening in Italy and Spain in particular, and then in Seattle and New York, we made a plan to care for our staff. Next slide, please. So the first step was restructuring our consult service. We knew that some of the highest areas of need would be the ED, the ICUs, and the medicine floors. So we went through an iterative process to try and shift our consult service from a heavily oncology-based service to one that would meet the needs in these other settings. And just to say, calling it an iterative process sounds prettier than it was. It was fast-moving and it was not pretty. Sometimes trying 3 different models within a week, and all trying probably 6 or 8 before landing on the one that served our own clinical service in our hospital the best. We changed from having nurse navigators in triage roles to having physicians and nurse practitioners because we knew that we would have to do in-the-moment coaching. And we went from having 5 consult teams to having 3 more robust teams. One doing virtual consults on our usual consult patients, one as an embedded team in the COVID ED and hospital medicine, and one as an embedded team in the COVID ICUs. We also mobilized anyone we could, pulling in clinicians from who usually focused on research, pulling our fellows into the hospital from whatever rotations they were on, and asking for help from our outpatient colleagues. Next slide. So we learned, similar to what Emily and Sean were just saying, that we needed to be flexible and open to rapid change. We held frequent team meetings to update everyone on the plan, including morning and afternoon check-in rounds for on-service clinicians. We kept an eye on national, state, and hospital statistics for the pandemic, and we participated in work groups for the ICU in particular, less so for the ED and for the medicine floors. And that brings me to my next point, which is that institutional culture really affected what we were able to do. We had heard, for example, that the ED might need a lot of support. And so we built a team and we were ready to help. But we were greeted with a very nice but slightly puzzled, "Why are you here exactly?" Whereas on the other hand, we felt much more effective in the ICUs in our hospital. And we estimate that we ended up helping with approximately half of the COVID patients in the ICU that were admitted to our hospital. And in fact, we got a note this week from the leader of the COVID critical care effort saying, "I know we're far from done with COVID-19, but I just wanted to thank you. We couldn't have done this without your team. I can't recall working with a service where the feedback was so universally positive." And I say that not just to pat ourselves on the back, but to show the impact that was had when we embedded a team there, which was not something we had seen before. Lastly, unsurprisingly, we saw a significant strain in our staff as we were doing all of this. Virtual palliative care consults for inpatients in particular are stressful and time-consuming, and they don't always feel like they're delivering good care. And the amount of suffering for our patients, for the families not allowed to see their loved ones, and for the staff caring for them was immense, like nothing we had seen before. Like what was happening in other hospitals, we sometimes had families with 2 or more members intubated in the ICU. We had a dying patient's husband who wasn't allowed to visit because he was testing positive for COVID a month after his symptoms resolved. We had colleagues who were family members of patients we cared for, and sometimes it was colleagues who were sick themselves. Now to Elizabeth.
Thank you, Jane. The second part of what we did for our inpatient service was to refocus our intensive palliative care unit. Traditionally, we're a 12-bed unit for oncology patients only, and we do a lot of upstream palliative care. So patients can be full code, they can be receiving chemo. And the way we restructured the unit was to be for COVID positive patients only. And goals of care, although not completely delineated, were much more delineated prior to arriving in the unit. So we envisioned this more as an end-of-life care unit where patients were already CMO or DNR, DNI, and the patient or the family assented to no escalation and care from there. Next slide, please. We have plenty of challenges in repurposing the unit. The first was telehealth. I knew that we couldn't open until there was supposed to be a system of iPads that were inside the room and outside the room so that we could see our patients at all times, because we didn't have rooms with windows or rooms or doors with windows on them. And I realized that we were opening and that system wasn't in place. So we ended up overnighting 10 super fancy baby monitors with video on them, so just so that we could know that we could see our patients all the time. We're normally an enormous interdisciplinary team. We're usually an MD plus or minus an MD fellow or resident, a pharmacist, usually with a pharmacy fellow and a learner, a social worker, often with a learner, 2 PAs, often with a PA who's onboarding. And then we have a chaplain once a week. And all of a sudden we were 1 MD and 2 PAs on site. And so we had to figure out how to round individually with all the other components of our team, and then still have our team have a full view of who all of the patients were. Emily also mentioned this in terms of the shifting plans and policies. In a time of high anxiety for everyone and great chaos, policies necessarily and plans were necessarily changing sometimes every few hours. So knowing what the latest PPE protocols were, knowing what the latest visitor policy was, wasn't always easy, and we made a lot of jokes about whiplash. The shift from doing a lot of upstream palliative care to doing end-of-life care only was one that I think we thought would be easier than it was, because it wasn't like we hadn't done end-of-life care before. However, this was so abbreviated, our length of stay was so much shorter than what we're used to, and none of our families were on site. So establishing those relationships quickly with the patients and families was more difficult. One wonderful problem that we had that we never wanted, that we never normally want to have our oncology patients in a double room, but we had a couple come in who had the same healthcare proxy, and the only thing he wanted for them was to be together. And so we ended up in just over 24 hours, with help from lots of different folks in our hospital system, creating a double room for them so that they could be together. And finally, I'll just say this is a new disease. Prognostication was very challenging. We designed it as an end-of-life unit, and we're actually very proud of the patients, several patients that we were able to discharge either back to home or to a rehab, and a few back to their assisted living. So it definitely kept us humble throughout. And I will turn it over to Barbara from here.
Thank you. With the forecast that the surge was coming our way to Boston, we had some lead time, and we anticipated that the number of consults to our palliative care service was going to exceed our on-site clinician capacity. So we knew we needed to extend our reach beyond our traditional modalities to prepare frontline clinicians to handle what we anticipated would be difficult conversations, symptoms, and suffering. Nurses in the emergency told us they did not know how to care for dying patients. People don't die in the emergency room. Nurses in the newly assembled COVID ICUs were not always career ICU nurses. But despite these apprehensions and wide gaps in palliative care knowledge among them, getting to mandatory ventilator training was a much more pressing need than coming to some kind of palliative care in-service. So we decided to collate what existing materials we had and to create a variety of strategies that would reach our end users in a variety of settings with content that was concise and that represented best practices and crosswalked to our pre-existing hospital policies, and we had to do it fast. A work group of clinicians, including our fellows, convened, and we created what Jane mentioned earlier, our palliative care toolkit. It's a collection of teaching resources that was accessible to hospital staff, both inside and outside the Brigham. This was a suite of materials that included, among other things, a link to our health system's COVID protocol that our team was able to update with a palliative care chapter. It included single-page tip sheets on symptoms and communication situations. Our communication faculty produced some short videos to model the time-pressured goals of care that we anticipated we could not help with. For nurses, frequently asked questions: how do I manage severe end-of-life symptoms? How do I talk to patients and families about COVID? We collated relevant comfort care and communication guidelines in this one virtual place. When clinicians needed in-person help with an evolving case, they could speak to an MD or an NP triage, as Jane mentioned, for either coaching, curbside recommendation, or a consult. One of our attending doctors set up a daily office hour for drop-in consultation, and bedside nurses could call a nurse resource line that was staffed 24/7. Next slide. This is a picture of the Palliative app, which contained our virtual a la carte menu of all these resources. This was loaded onto a homegrown reference application platform built by our colleagues at Brigham and Women's Hospital at their Innovation Hub. The advantage of this was that as the material was created, this progressive web app allowed us to manage the content and update it internally. This is accessible both on smartphone or desktop. While our enduring education materials and tip sheets, videos, protocols, and outreach structures were tailored to the COVID as we knew it, we anticipate these will be adaptable in our ongoing work and in the event of a future surge. I'll turn it back to Jane.
Thank you, Barbara. So we came up with a variety of ways to support our staff. This was the fourth major part of our response to the pandemic, including putting one of our attendings in charge of overseeing these efforts. So in addition to the twice daily check-ins for on-service clinicians, we continued our weekly remembrance, led by our director of bereavement and our team chaplain, to remember the patients who had died in the previous week. We also had weekly psychosocial rounds led by a psychiatrist to debrief difficult cases and talk about how the work was affecting us. We also had several times a week psychologist office hours that we could drop into and discuss anything that was troubling us. In addition, we made sure to include a little bit of lightness and fun in the midst of all of this. So for example, our department held the first annual pandemic Zoom dog show, which was a roaring success. And then there were lots of institutional resources made available to all staff and an emphasis on self-care and mental health that I have never seen before. Next slide, please. So hopefully you've been hearing some of the lessons we've learned as we've been talking. Some of the important ones are, first, that crisis can lead to incredible innovation as well as team cohesion. Because of the different reconfigurations of our service, many of us got to work in the trenches with colleagues we don't usually get to work with. And we're closer as a group as a result. Two, flexibility and openness are critically important, just like Sean and Emily were saying. There was no way to predict ahead of time exactly what would be needed. So we made a plan, and then we made another, and then we quickly made another when we needed to. Third, having said that, prioritization was really important, and holding intentions that then could be modified was helpful for us. So one intention that we held on to a little more tightly was self and team care. Fourth, embedded models are powerful, as we saw especially in the ICU. This was so striking for us, in fact, that it's informing the structure of our clinical service moving forward. And then five, learning can happen even in a pandemic, but only if the surge isn't drowning a team or an institution. We were really busy and really tired, but we weren't drowning. And so not only did we learn, but we were able to teach others. Next slide. So that's it from us. We welcome hearing from you with any questions, and here is our contact information if you want to contact us afterward.
I'm really just in awe of the presentations today and all of the work that you have done to support the needs of seriously ill people who are experiencing COVID, as well as all of the other care that you're providing. So really a remarkable panel presentation, and thanks to you all. I just want to share a couple of remarks about what we heard today, and maybe sharing what we didn't hear today. So about Mount Sinai, this was really an extraordinary presentation. Thank you both for that discussion about the care that you've been providing. You went from 0 to 100. In a very short period of time. You went to 2,000 out of your 3,000 beds being COVID, and 1.6 times your max capacity for critical care. There was no ramp up time. There was no time to be thoughtful. There was no time to really deploy intensive training. It all just happened. And the way in which you met the need and deployed palliative care and the description of what you provided, really attending to the symptoms and attempting, mitigating things like dyspnea, problems with breathing related to COVID, and also focusing on the goals of care conversation really allowed you to take away from an overburdened remaining hospital staff to save lives as a whole. So the work that you did was immediate, and it was responsive, and as a result, many people were saved. And I can say the same thing about the approach done at Brigham and Women's, where the ramp up time was slower and progressive, and certainly overwhelming as it was anywhere else in the country, and still is in many places in the country. But you had more time, and that time allowed you to do a different approach, to embed and to really think through a range of things that you might be able to deploy instead of using palliative care where palliative care can be part of a team. And that really requires training for people to understand the services of that team. So these are two very different ways of approaching the work that you've done. And so for my first question, I'm just going to start with a very generic question about where you are now, and based on what's going on, what will remain and what have you learned? And I also would just encourage you to share things that you would avoid for next time. What are the negative learnings, because that also can be helpful to those out there who are going to be either expanding existing palliative care and are right now struggling, or people who are moving past COVID, and based on these learnings, what are we going to do and how do we prepare for a next surge? So let me start with the Mount Sinai team. I'm leaving it open to either or both of you to make comments on this.
I'll let Emily comment.
Great, thanks, Sean. So a couple of things in terms of where we're at now. Our 24 patch line is still in existence. We're still holding on to this until the city opens up, because we're really not sure what's going to happen as business restarts. So we still have the line being staffed by our senior fellow rather than attending right now 24/7. The volume of calls has already come down. It's averaging about 1 to 2 a day rather than 35 a day at its peak. And then our ICUs are sort of in a state of transition. We had embedded programs in some of the ICUs, and then they really like this idea where we go to all the ICUs and check in and round and ask them who we should see. So we will probably settle somewhere in between, because 8 ICUs is quite a lot to round. We haven't yet figured out where that middle ground is going to look like at this point. And then our primary palliative care program, I have to say, we were pleasantly surprised by the overwhelming response of pretty much the entire hospital and their receptivity to primary palliative care. So I feel like we have a lot of work there to be done that could be continued. We had trained up our opto residents who were deployed, and they have been the best primary palliative care advocates. They did great initial surrogate identification and values and preferences, and they were the one who stayed with us for the longest. Even when all the other residents deployed had left, they were still with us. So I think that there are plenty of opportunities there that we probably need to tap into. And then I think your second question was, what would we have done differently, or things not to do? And I think the only thing I could think of is during that time, we received a very overwhelming amount of support, is really being able to be thoughtful of what we could take on and what we should say no to. Because at the very beginning, since the numbers were increasing so rapidly, we were saying yes to everybody who was willing to help, and realizing that there were times these people who are not familiar with the health system, we needed to invest a lot more work to get them trained up to be able to help. And it took us a while to sort of catch on, to realize that we need to sort of set a limit to what kind of help we take, what is going to be helpful and what is actually not going to be as helpful. And that was probably the one big thing that we realized, halfway through, that we need to start triaging the help that everybody was offering. Anything else to add, Sean?
That was very helpful. And I guess it is a universal learning, knowing when to say no. Really, really helpful to remind everybody. I'd like to turn to our friends at Brigham and Women's and Dana-Farber, if you also would like to comment on the question.
I'm happy to. So in terms of where things are now, things have quieted down a lot. So we had at our max about 113 COVID patients in the ICU. We currently have 15, just for a sense of scale, sort of how far out of the surge we've come. And so our role in the COVID ICU obviously is shrinking. We've turned our COVID IPQ back into our regular oncology IPQ. I'm happy, Elizabeth, for you to talk more about that if you'd like. And we're sort of in the process of thinking about what are the things that we've learned in the course of this that we're going to carry forward. One of the main things that I mentioned before is the power of embedding, which we'd had a little bit. We have an embedded model, a sort of a population health model for our patients with end-stage renal disease and also for our patients with end-stage heart disease. And all of the rest of our patients are taken care of by any member of our consult service. And we're realizing that we're going to be more specific and adopt more of a population health model kind of moving forward in a way that we had not anticipated. And a lot of that is due to what we learned in our partnership with the ICUs. In terms of things that we wish we kind of knew now that we didn't know then, I would say one of the main things was we were not entirely prepared for how distressed the entire system ended up being, not only our own team, but all of the consulting team, all of the referring teams, all of the clinicians in the hospital. There was so much suffering. The patients were suffering, the families were suffering, clinicians were suffering because they couldn't practice to their full extent in order to be able to be helpful. I think even for our team, some of the basic tools that we use to be helpful, including being present at the bedside, being present with families, holding someone's hand, being able to communicate in a very direct and sort of compassionate way, all of those things were hindered either by PPE or by distance, by language, by technology. So the level of distress, of clinician distress, was very high. For our own team, we had lots of resources, as I said, and I think we were able to navigate pretty well. I think what we didn't know what to do with was what was our role in managing the distress that we were seeing in our colleagues. And I think for some, we tended to take on a lot of that and think that it was our role to try and address it or fix it. And then others of us didn't feel the same way. And so we had to do a lot of discussing as a group what was within the bounds of our role and what was not, in terms of helping our struggling colleagues with what they were experiencing also.
I guess I can add to that. We just closed our COVID IPQ 2 days ago. While we were open, we took care of about 40% of the deaths from COVID in the hospital. I'm not sure if we know, we're sort of now anticipating needing to reopen possibly in the fall. I think we're all going to take a deep breath, figure out what we learned, but some of the things that we want to do before that is to get a few policies in place that the visitor policy, for example, still needs to be tweaked. Some of these things we'd like to get more set before ramping back up in the fall. So I think it's sort of like we're in this regrouping moment. What would we like to go better next time? That's one example.
And I could just add from the nursing perspective, I think that the embedded model, particularly in the COVID ICU, was novel, and the nurses there really see a future path with setting up communication with when the regular ICU nurses are back, to help them with identifying cases where there's need or there's nursing distress around taking care of those. That rounding with ICU teams can be very time intensive, and that this might be another pathway for nursing to support nursing. I'm also struck by what you from Mount Sinai talked about, the lack of calls initially when people were overwhelmed. And despite setting up a resource line for nursing, we had very few calls. And that helps me to understand possibly why that wasn't adopted as much as we thought it would be. And I guess finally, as a manager, for me, thinking about how to temper the eagerness among my most zealous staff who just didn't want to leave the hospital. So that's a future thing to think about.
That's an amazing statement, Barbara. That people in the midst of the crisis wouldn't want to leave the hospital. And I really want to say hats off to your entire team for their presentation and the interprofessional nature of that presentation, really talking about how you were drawing on different members of the team. And so I'd like to do a gentle lob back to Dr. Morrison. I know at Mount Sinai, you are interprofessional to the core. The presentation did focus primarily on the physician role. I wondered if you just might want to add anything about what the other members of the team, like the 300 social workers that you trained and, the chaplaincy, et cetera, if you just wanted to share for a moment about the role in the response.
Yeah, so let me address that in two ways. The first is to say that obviously our palliative care interdisciplinary team was critical, and the members of that team, our nurse practitioners, our nurses, our social workers, our chaplains, our licensed massage therapists who put together virtual training was absolutely key. What makes Mount Sinai a rather unusual institution in terms of a medical school is it is a medical school without a university. And so that when COVID came and overwhelmed the health system, the only extra bodies that were available for the palliative care service were our learners. And because we don't have a school of nursing, we don't have a school of social work, we don't have a theology program, the only available person power that we had were physicians, and they were physician trainees. So that we had to build our new programs with what we had, not what we wanted. And what we had were ophthalmologists, residents. What we had were dermatology residents. What we had were our 15 fellows who, because it isn't a medical school, were physicians. And in fact, our interdisciplinary team members, we had the same issue that Barbara did, is we had to tell our interdisciplinary team to go home because they realized that they were overextended. And I think that was, as I said, a relatively unique for our health system. It was relatively unique for New York, and it had to do with the numbers that we had, not in any way to what we believe palliative care should be. it was making the best of what we had.
Thank you so much for that. So clearly, both of your teams have not wasted a crisis in terms of building and scaling and thinking about how these resources will be used in the future. And this is a great example for all of us. Some people out there would say, we don't have your resources. And I'm going to give you each 30 seconds, one member of each team, to respond. What's the one thing that you would tell to somebody who says, we don't have your resources, what can we do?
I'll let Boston start, because we're not Harvard, so we definitely don't have their resources.
I would say that it's important to be strategic, that there's no way to meet all of the need to the extent that you're going to want to be able to, and that can't be the goal. And so choose carefully who your partners are and where you're going to put what resources you have, and be gentle with yourself and know that it may not be possible to do everything that you want to do.
Fantastic. Thank
I would
you.
just-
And I'll bring back to them.
Go on, Amy.
Oh, no, I'm sorry. Back to you.
And I would just add to that both our programs did not start with these resources. This took a while to build, and that COVID presents, despite everything awful about it, an opportunity for palliative care, because it presents an opportunity to demonstrate the absolute critical need of palliative care within a health system. And the support for palliative care within Mount Sinai, and I think Emily will concur, is tenfold greater than when we started. So it's not only about being strategic, but it is about being on the front lines, putting yourself forward and not hiding. As Jane said, being strategic so you know what to offer, because we will get through COVID and COVID will go away. And this is the opportunity to really demonstrate the value of palliative care and to build as a field.
Thank you so much to all of our panelists. And now I would like to turn it back to Lori Gregg.
Thanks so much, Amy. And on behalf of the team here at the National Academies, I would like to thank the moderator and our speakers for taking time out of their extremely busy schedules to share their expertise with us. As you may know, the Federal Office of Science and Technology Policy and the Office of the Assistant Secretary for Preparedness and Response requested the National Academies to establish a new standing committee on emerging infectious diseases and 21st century health threats to inform the government on response to the pandemic. They have released a number of rapid expert consultations that are available on the committee's website, the link to which is included on this slide, along with several other links that contain useful information. As noted at the outset of the webinar, this webinar has been recorded and will be archived at this site for future viewing. We encourage you all to share this link with your colleagues and networks. Again, I thank everyone for participating in this webinar today, and I hope that you will join us for future events as well.